Thanks very much again, Mike. All right, so I think we can all agree that in-stent restenosis and stent fractures obviously remain the Achilles heel of stenting. And I hope to dispel this notion there that DCB is this magic panacea for in-stent restenosis and that there indeed is another potential treatment, which is, again, to use a covered stent. And hopefully I'll convince you that there's a sweet spot for covered stents in the treatment of long SFA and stent restenosis. So let's just start off with a real-life clinical example of a 62-year-old guy who came in with unstable angina. We stented his circumflex, but he couldn't do cardiac rehab because he had bilateral SFA occlusions, and this was back in 2004. And you can see typical, very long total SFA occlusion. We're able to reconstruct that with a bunch of bare metal stents. But unfortunately, he required 4 interventions over the next few years due to recurrent in-stent restenosis. So the question is how to treat that. Well, we've seen from the previous lectures that PTA certainly is not the case, especially for Tosaka 3 occlusions where the recurrent restenosis rate exceeds 80%. You just heard about the laser Excite ISR trial from Chris, but not to belabor the point that the results at 1 year were pretty sobering. If we look at combination laser and DCB for in-stent restenosis, this was a randomized trial by Dr. Gandini's group in Italy. And suffice it to say that there was a benefit to adding drug-eluting therapy to atherectomy in this particular study. This was another 2-center study from the United States with very similar data, 72% versus 50% at 1 year in favor of combination therapy. Debate ISR was a randomized trial of DCB versus PTA for FEMPOP restenosis in diabetics with median lesion lengths of about 13 centimeters. And you can see while the initial results looked quite promising, there was this late catch-up phenomenon by 24 months. And indeed, in their 3-year follow-up, there was in fact catch-up between the DCB arm and the PTA arm. And again, the more complex the disease, the higher the likelihood of recurrent restenosis. Copacabana was presented, the 2-year follow-up was presented by Gunnar Tepe at the LINC meeting. And again, median lesion lengths here are about 12 centimeters. And again, illustrating this late catch-up phenomenon and basically attenuation of the DCB effect out to about 24 to 36 months, such that there was a pretty significant drop-off in the patency at that time. The Pacuba trial was mentioned earlier. Again, this was a pretty miserable follow-up results, but again, perhaps this may be related to the particular DCB involved. The ECHO-ART trial was a Chinese and Italian study looking at that particular DCB for in-stent restenosis. And again, 1-year results look fantastic, but went from 92% to 54% in the ensuing 12 months. So I think we can agree that there are very significant limitations of DCB for in-stent restenosis, particularly as monotherapy. You still balloon, which means you still have recoil, you still have dissections. It can be very challenging to treat hard calcified, underexpanded stents or fractured stent. And there is a much greater need for bailout stenting with these more complex lesions. What about Zilver PTX for in-stent restenosis? This is Dr. Zeller's paper from a few years ago. Again, more medium-length lesions with about a 40% TLR rate at 1 year. The Zephyr trial looked, this was again, Japanese study. And if you look at the 1-year incidence of restenosis and major adverse limb events after reintervention for drug-eluting stent in-stent restenosis, the numbers are very, very sobering, leading the authors to conclude that after reintervention for DES-ISR was suboptimal, especially class 2 and class 3 lesions had an extremely dire prognosis. So what about Viabond for in-stent restenosis? Well, we certainly know that it's safe. You don't have to worry about another stent snagging or damaging the original stent. Atherectomy can potentially damage the original stent. There's a very low risk of embolization because this is neointimal hyperplasia. And you can trap, as that last case I think illustrated elegantly, you can trap plaque and thrombus and make for a very quick and simple intervention. And you don't have to have another laser tube cut stent is going to make that vessel a lot stiffer. You avoid that with with the Viabahn, and there is virtually no risk of subsequent stent failure. The RELINE trial, of course, was the definitive randomized trial of Viabahn versus PTA for in-stent restenosis. This basically was already published and presented, and you can see there was a real-world study here, 19-centimeter lesion lengths. About a quarter of these were total occlusions. And again, you can see a very significant benefit in terms of covered stents versus PTA, extending out to 2 years. And this also included significant benefits in terms of TLR rates. And importantly, there were no stent fractures at 12 months. And again, to reemphasize the importance of differing patterns of restenosis, again, important to remember that restenosis for a Viabahn is usually a very short focal stenosis versus a more diffuse and proliferative in-stent restenosis with bare metal stents. And we recently completed the RELINE MAX study, which was done primarily in the US with 5 European centers. So we'll have some additional data in this regard as well. PQ bypass, again, is really designed more so for long native occlusions, but you can potentially see how it might be applicable for patients who have in-stent restenosis as well, assuming that you have a free entry point and exit point in that patient's anatomy. So you remember my poor patient who had the 4 interventions for in-stent restenosis. Again, this was back in 2006. This wasn't very complicated. Ballooned it, put in some Viabahn stents, and got a great looking angiographic result. And in fact, he has stayed patent since 2006. So why use covered stents for in-stent restenosis? Well, I think we've seen that atherectomy and DCB and DES are effective for short to medium length lesions, but the results for long FemPop in-stent restenosis are really quite modest with very significant patency attrition over time. We have level 1 evidence, of course, that they are superior covered stents are to PTA, and that they, again, still are important and viable in this day and age, and they remain an excellent treatment for long ISR lengths and for more complex disease. Thanks.